So the question that I was sent, that Tom sent me when he very kindly invited me to speak here today, was what sort of business models might work in this space, and what sort of sustainable business models was I familiar with. And since I've been working very hard to implement a mobile health project at scale in Bihar, I haven't really had time to look around me, so I'm going to talk about the two business models that I know a lot about because I'm involved in implementing them right now. And it's also worth noting that it's been very interesting to hear about pilotitis and all this talk of pilots, because as the BBC, we don't pilot. I mean, you could imagine that the BBC is a global media organization. It's very hard to pilot a drama that you're supposed to be putting out to 70 million people. It goes out. And with that spirit, we engaged in this project. So I should add, though, that we do a huge amount of user testing in the development of our services that's very iterative. So it's not that we don't test what we do, but we do go to scale very rapidly. So we've just launched 2 mobile health services in Bihar, a very poor state in India with a population of over 100 million, including 22 million of women of childbearing age. There are 200,000 community health workers in Bihar. We've developed 2 services. One is a training course around behavior change. And this is designed to improve community health workers' ability to change behavior around maternal and child health. And it's structured around a 33-month continuum of care from pregnancy through till the child is 2 years of age. And we've also developed a job aid, which is designed to be used during counseling sessions that healthcare workers have with families on a day-to-day basis. It's a partnership with 6 of the largest mobile operators in India, accounting for 90% of the market share in Bihar, which means that 90% of mobile subscribers in Bihar can access our services. It's with Airtel, BSNL, Idea, Reliance, Tata, and Vodafone. The IVRs, they're all IVR services, which mean they can be used on any handset, on common short codes and common tariffs across all participating operators. I don't know if that sort of jargon to this group, but a short code, is a 5 or 7-digit number, depending on where you are, that means that your service is accessible across multiple operators from a memorable short number. And when I say common tariffs, what I mean is that we've negotiated the same cost to the end user or to the BBC for those services across all the mobile operators. We have been successful in negotiating a 90% reduction in the standard IVR call rates with those operators. And it was interesting to hear earlier about the discussions about government involvement, because we have involved the government of Bihar from the very outset, as well as the Department of Telecommunications and the Telecommunications Regulatory Authority of India from the get-go, and we've had their complete backing and support throughout this process. And it's not that it was actually in a way quite easy to convince them that it was worthwhile, but to get anything done was another matter, and that involved constant follow-up. Okay, so I'll talk a little bit about mobile kunji, which means key in a kind of cheat sheet way. It's a toll-free multimedia job aid for community health workers designed to be used during their counseling sessions with families in Bihar. Actually, I have one. And I love describing this as a multimedia toolkit, because it's multimedia makes you think of something very kind of fancy and high-end, but it's actually extremely low-tech. It's a series of color-coded cards. They're color-coded according to the stage of pregnancy or birth or age of the child up till the child is 2 years of age. They're designed to be used by the community health worker while she's counseling the family. She counsels up to 56 women per week. And it has information, illustrations on each of the cards, information on the back. And then there's a short code at the bottom. And there are 36 unique short codes here, again, across all of those 6 operators that I mentioned. And you dial the short code to hear the audio that corresponds to the information on the card. And so in that way, without the need of a television, VCR, DVD player, MP3 player, any particular handset, any smartphone, you have an audio-visual handset. The handset is toll-free, and we negotiated very, very low rates with the mobile operators for the calls that would be billed to BBC Media Action. The Bill and Melinda Gates Foundation is funding the cost of the calls for the first year. But after that, it's already been negotiated and agreed with the government of Bihar that the government of Bihar will be funding those call costs from 2013. And the reason that the government of Bihar is willing to pay those call costs, despite the lack of a randomized control trial or impact results or baselines, midlines, and endlines, is because they've seen the response of community health workers towards this product, which has been overwhelming. We're rolling it out right now with 40,000 healthcare workers, scaling to 200,000. We're training 2,500 healthcare workers a week in the use of this product right now. And we have 100% attendance over a 3-day training course. In fact, we have frontline health workers from other areas who we haven't managed to train yet, coming physically to the training center and demanding to be trained. We had 70 healthcare workers show up at one venue saying, "You can't continue this unless you train us too." The next service that we've also launched is Mobile Academy. This is an IVR training course, and it's designed to expand and refresh community health workers' knowledge of life-saving health behaviors and enhance their interpersonal skills. And the stress really here is on improving their communication skills, which, given that they haven't had any training in communication, but we're expecting them to communicate every day, is an area that's been sadly neglected. The course is actually billed to the frontline health worker at 50 paisa per minute. And so this is where the sustainable business model comes in. This is the private sector business model as opposed to Mobile Kunji, which is the public sector business model. The course is 160 minutes long, so it costs about $1.50 for the community health worker to complete the course, and she can do it as quickly or as slowly as she likes. It took a lot to convince the operators to come down to this rate, but there is actually revenue share built into this 50 paisa per minute. And that revenue share is, there's a percentage that goes to the operators, a percentage that goes to our technology provider on mobile, and to cover operational costs. It's interesting because I think you just mentioned earlier that you were concerned about how the bottom billion or the base of pyramid subscribers would be willing to pay for these kind of services. And we did do a huge amount of research before we developed these services, both quant and qual. And the response was overwhelming that the community health worker was willing to pay, that they could afford to spend somewhere between 5 to 10 rupees per month. And this course can be done as quickly or slowly as the health worker likes. So they can take up to 12 months to finish this course on their phone. So 80 rupees as an upfront payment would probably not be possible for a health care worker, but spread over 12 months, 80 rupees is actually very affordable. So here is an instance of base of the pyramid subscribers paying for a service where there's then a revenue share to help cover costs. However, that revenue share just covers costs. The profit margins are minuscule, and additional revenue streams are definitely going to be required to make the service commercially attractive in the longer term. But I think there are a lot of ways that this could become commercially attractive, because it's not just about call share revenue, it's about engaging in the long term with potential customers. Very quickly, since I've run out of time, so how were these business models developed? They were developed in, I suppose, a very kind of traditional way. So we established the size of the target audience, the degree of mobile penetration, the penetration amongst the target audience, and you'll be happy to hear that 85% of community healthcare workers in Bihar own their own mobile phone. their likelihood to pay for the service. This was done through a large-scale quant survey, as well as qual focus groups and one-to-one interviews. Then an estimation of projected take-up rates based on our rollout plans. So we did extremely complex calculations based on high motivation, medium motivation, and low motivated community health workers, and their motivation linked to the degree of, or the amount of training that they were receiving and incentives. Then we had to establish all our internal operating costs, which we've done. Then identify the benefits for the mobile operators, and this is a really critical point, and something that I think is critical to the success of this, and recognizing that it isn't, as I said, just about short-term call share revenue. There are a lot of benefits in having a daily relationship with your subscribers that is in-depth and potentially collecting a lot of valuable data about them. Then establishing the mobile operators' operating costs, which you would think would be easy, but it's not data that they share readily. Then looking at taxation, which actually is the single thing that can be the biggest downfall for your business model. I mean, in our business model, taxation could be as much as 57% of our revenue goes into direct and indirect government taxation. And then identifying the benefits for government. Obviously, taxation is one of the benefits, but there are many others as well. And then finally, the whole process of selling this to both the operators and government, which, as I said, takes really months of daily, I don't like to describe it as harassment, but you really do have to be persistent. Thank you.